welcome to today's seminar, Interventions for Supporting Homeless Individuals who use drugs. Um, the definition of homelessness is always an interesting one, um, because obviously you have people who have nowhere to live. So in the UK, you will traditionally see them living in tents or living in shop doorways. But we tend to broaden that definition to people who don't have a home. So they might be what we call surface sofaing. Um, uh, so that means they're basically staying on someone's sofa or in a spare room for a temporary, or they might actually be in temporary accommodation in a hostel, but they don't really have somewhere they can call it home, that they can call the place home. And I think what inspired me to try and look particularly at the most vulnerable group of people in society is trying to find tools of ways that we can support people. And so today we're looking from both an academic and a practical implication. So the academic part is, how do we involve vulnerable people in research? Because in many ways, a lot of traditional research is not actually involving the participants themselves in co-producing research. And there's some been interesting work, particularly from Katie, around this area. One particular activity I was involved with was the study of Bouverdale, where we involved a lot of peers to be involved in that part of research, and very innovative. So I'm interested looking at that perspective. And then the second part is looking at practical ways that we can support people. So um, as a provider of services in Wales, I'm aware of what Kaleidoscope does, and um, it is tricky in our country because we are still governed by what I would consider to be an outdated Drugs Act of 1971, which still tends to criminalise people rather than help people from a health perspective. And I believe that drugs is very much a health issue rather than a criminal justice issue. So how we support people in that way is really challenging. And when I look at the people we try and help, the problems of people who are homeless is, of course, they're highly visible. So any offences they do commit, they're going to be spotted much more than, say, someone who lives in a mansion, who's a pop star and who takes cocaine in the privacy of their own accommodation. And of course, the supply they get is less visible as well. It well might arrive in an Uber rather than literally someone giving you the drugs on the street. So there's that part of it. We know that people who are homeless have higher degree of mental health, which again means there is greater challenges in supporting people. They themselves, because they've been let down by society, have less investment in society, so their behaviour can be more challenging. And these are some of the things, like, for example, treatment. The traditional way we used to treat people, and we still do, is to give them methadone. Often people might actually collect their methadone. If they get it supervised, it might be all right. But if you're not getting supervised methadone, then you are holding methadone in a very unsecure location. And if you're, for example, someone who's quite frail, or someone who's not physically strong enough to fight off someone else, you well might lose your methadone to someone who's a bit more powerful. So there have been various ways that we've been trying to work with people on medication programs such as Bouverdale, making sure we can do better outreach, which Chris will be talking about, making sure that actually we empower people through peer-to-peer work. But the two challenges that I just leave you with, which is the nonsense that we have in the UK, is one of the steers, because of nitrazines and other additives to our heroin supply, we are telling people not to take alone. Make sure there is someone with you. But in hostels, where our homeless communities often live, we're telling them they can take their drugs, but only in the privacy of their own room, i.e., not taking together and not taking actually precautions of their own safety. And then the other nonsense that sometimes, so I'm just highlighting these 2 points, but the other nonsense that we sometimes have is, you're not allowed to inject, quite rightly, on the street. We don't want paraphernalia to be left on the streets. But as someone who provides a needle syringe exchange, I know someone is homeless, but where can they actually take those drugs safely? If they take them, for example, on my premises, that homeless cohort, I could be arrested for assisting their drug use, even though I'm actually providing them with the paraphernalia to take those drugs. So there's a lot of strange issues that we have with communities we support, and sometimes it means our support doesn't always make sense to the person getting that support. But I'm going to start today's seminar by looking about how we engage people who take substances. And I think it'd be really helpful to hear from Professor Katie Holloway about some of her work in making that happen, so we can have a much more evidence-based approach to the way we support people. Katie, are you happy to talk to the delegation here? I know you have a presentation.
Thank you. Can you hear me okay?
I can hear you.
Great. I'll share my screen. How's that? Is that okay? Yep. Okay, brilliant. Okay, so thank you very much for the introduction, Martin. So my name is Katie Holloway. I'm a Professor of Criminology at the University of South Wales. I've been involved in drug and alcohol related research for many years now, and over the course of that time, I've got to know the services across Wales very well. And I currently work very closely with Kaleidoscope, hence my involvement today in this webinar. So Martin asked me if I would talk about peer involvement in research in Wales, and so that's what I'm going to do for the next 15 to 20 minutes or so. Okay, hopefully my next slide will come up. Okay, so my presentation is split into 4 parts. So first of all, I'm going to look at what do we actually mean by peer involvement in research. Some of you might already have a pretty good idea about what this means, but it's always a good idea to start with definitions of key terms. So I'll begin with a little section on what it actually is. I'll then move on to think about why is it important and useful to involve peers in research, and then talk a bit about how we do this in practice, and then I'll spend most of the time talking about some examples of peer involvement in research in Wales. Right, so first of all then, what is peer involvement in research? Well, it's really when we involve people with lived or living experience of substance use problems, or involvement in treatment, perhaps even either as a family member or a carer, when we involve people with that lived experience of drug and alcohol use problems in conducting research, or perhaps even guiding the conduct of the research process. So it's bringing in that personal experience of drug use into the research process. So traditionally, typically in the past, peers have been involved in research really as subjects. So they are the subject of the research. But there's been a real shift in recent years to actually getting peers involved in doing the research or conducting the research. Now, the actual role that peers play in the research process is varied, and the extent of their involvement varies too. So there isn't a one-size-fits-all approach. It can vary in terms of their involvement at different stages in the process. It could be that you have a peer who designs the project and conducts the project and interprets the findings and presents the findings. So they're involved in every single part of it. But it could be that you have a peer that helps at particular points in the process. Or it may be that the peers guide other researchers to do the research. So there's a real variation, and all of it is extremely valuable. So on my next slide, I'm going to look at what are the reasons why we do this. If we think now about how often peers are involved in research, when you think back, I wonder, why didn't we do this right from the very start? Why is it only a relatively new thing? And I've put some bullet points on this slide showing some of the main benefits really of involving peers in research, but I'm sure there are many more. These are just some of the key ones. So first of all, the authenticity. So when you involve peers in research, they bring their real life authentic experiences and perspectives to the research. They know the questions to ask and how to ask them to get the best data. In terms of understanding then, so having peers, people with lived experience of the issues, can provide insights and understanding that might not be apparent to researchers without that experience, without that direct experience. So they know what it all means. Now, The next one I've put in bold, this is empowerment. Now, I had a chat with a good colleague, friend of mine, called Tommy from Kaleidoscope. He's co-production lead there, and I was just talking to him about this presentation, and he wanted me to really emphasise that getting peers involved in research is really beneficial to the peers. It can empower them, it gives them a voice, it gives them new skills. We train them in how to conduct research and how to analyse the data. It can really boost their self-esteem. They feel like they're making a real difference. So empowerment is a really important reason for involving peers in research. But I think it's also really important in terms of improving the quality of the research and the validity, making sure that we're actually exploring the key and important issues. Having peers involved can give you the checks and balances to check the researcher's own assumptions and interpretations, making sure that you're interpreting the findings properly and making sense of the findings. Another one in bold here was something else that Tommy wanted me to mention. So peers can bridge the gap between the people who are doing the research and the subject of the research. So you can get more trust, you get better engagement from the community with the research process, and then also with the findings. It's a hugely important reason there. And then finally, advocacy. So peers who've got direct experience with certain issues like homelessness are often real passionate advocates for change. So involving them in the research can help to address social inequalities, injustices, and systemic barriers as well. So how do we get peers involved in research? And how do you actually make it work properly? Well, it's really important that peers are engaged really early in the process. So right from the beginning, when you're starting to think about a research project, speak to people with lived experience. Is this the right question to ask? Is this something that's feasible? So right from the beginning and then all the way through at the critical moments, making sure that you're developing your data collection tools appropriately, that you're asking questions in the right way, using the right terminology, and that you're then interpreting the data properly and then sharing it in appropriate ways that everybody can understand. So you need to make sure that your peer researchers are properly trained. You need to make sure they know how to collect the data, what to do with that data, and really importantly, we need to make sure that the research that's conducted is ethical, that it aligns with ethical codes of conduct and procedures. So we want to protect our research participants, but we also want to protect the peer researchers too and avoid any harm. We want to make sure that it's a supportive and respectful environment where the peers can speak their minds and talk about their experiences freely and comfortably. I've put a bullet point there about compensation. So this might be about making sure that any peers' expenses are covered, but it could be also respecting engagement in other ways. So acknowledging their involvement and rewarding it in other ways in terms of perhaps their recognition. And at the end of a research project, and perhaps all the way through, it's getting feedback from the peers and reflecting on their involvement so that lessons can be learned for the future. Okay, so we're going to talk about some examples of some peer-led research that's taken place in Wales. So Martin alluded earlier to a project about Buverdale, and I'll come on to that in a minute. But one of the first big peer-led projects that took place in Wales that I was involved in was this project here, which is about lessons learned from COVID-19 for substance use services. So this was a collaborative project with all those organisations where there are those icons in the middle there. All these organisations came together right at the start of the pandemic and realised that something needed to be done. We needed to explore what was happening to service users, to the services themselves, and find out what can we do for the future to protect services and help them optimise service delivery in the future in the event that there may be other global crises and pandemics. So Kaleidoscope, Barrels and myself from the University of South Wales, we designed a project with support from these other organisations, and there were three strands of the research. So one focused on service users, one on the frontline staff, and one on senior managers and decision makers. Now, the one I'm going to talk about briefly now is the one that was led by Kaleidoscope, which was the service user strand. So this was peer-led in that it was led by a team of 7 peers from within the services from across Wales. So these service users were trained, they were supported, they developed an interview, questionnaire schedule. They played a huge role right from the very beginning, and then they gathered the data themselves. They conducted what we've referred to as telephone survey interviews. So they contacted service users and spoke to them over the phone for sometimes it was for a couple of hours, gathering the information, which they then entered into an online survey. So we call these survey interviews. And we explored substance use during the pandemic, what happened to their personal lives and their access to treatment and support. So how did the lockdown period affect their access to treatment? So this peer-led piece of research, the benefits of having peers involved were just enormous. The sample was huge. It was 202 people took part in a survey interview. 202 service users, that's massive. The sample was much more representative than might be usually from non-peer-led projects, certainly from my experience. There were many more women that took part in this survey than has ever taken part in research I've been involved in. It was more like an equal sample of men and women. We discussed this as a team, why this might be, and we thought that maybe the peers, that the women felt more comfortable talking to peers, or it may have been something to do with the pandemic, that people thought that women might have been more adversely affected by the pandemic than men and wanted therefore to talk about it. But having the peers there to discuss these important issues was fantastic. The data was very detailed and appeared to be very candid and very honest views, suggesting that the peer-led approach was enabling people to talk very openly. The peers benefited enormously from taking part, which links back to what I said earlier about the benefits of peer-led research, giving people that self-esteem, making them feel really important, having their voices heard, and the participants benefited too from those conversations. And some really important lessons were learned from that project for the future delivery of services, and the importance of a hybrid approach and a flexible approach that meets the needs of individual service users. So the next project that really built on the lessons learned from the pandemic project was a peer-led review of Buvidal. So Buvidal is a form of opioid substitute treatment. So it's long-acting injectable buprenorphine. So in the UK, it's Buvidal. I think other names are Brixadi and I can't remember the other one, that's Sublocade. I think that's used in the United States. So this project was commissioned by Welsh Government, and they wanted to emulate the peer-led approach from the previous one that I've spoken about. And so a team of peers with lived experience of opioid substitute treatment came together. They designed and conducted interviews, big sample of nearly 100 people who'd been prescribed Buvidal. The interviews ranged from 25 minutes to an hour, and many of the people taking part were in unstable housing prior to starting on Buvidal. And this project highlighted some really important recommendations for the future delivery of Buvidal. So, for example, in relation to the initial assessment, the peers emphasised the importance of making any new patients aware of the full range of possible physical and emotional outcomes that might result from taking Buvidal before they commit to treatment. They recommended that there's a robust pathway to identify and resolve issues relating to a return from trauma that was associated with taking Buvidal. They recommended that there were more diversionary activities for patients who were on Buvidal, who were achieving this new clarity of mind from taking the medicine and had more free time in which they needed to fill. And then finally, these are just a few of the many recommendations from that report, but this one was about advising new patients about the importance of not using heroin or methadone prior to their appointment, if they wanted to avoid that possibility of becoming seriously ill. Okay, there's some ongoing research taking place in Wales, and this is being led by Kaleidoscope, Tommy in particular, co-production lead. I've mentioned a few times now. So this is some peer-led research looking at introducing enhanced harm reduction facilities, which will include a safe space for people to use and inject substances, which Martin mentioned at the start there. So this has involved a survey of people who might use that facility. So 60 people have taken part in this survey. So the peers designed the survey, developed the questions, and it's all about helping to justify the need for an enhanced harm reduction facility and to inform the design of that. So the analysis is underway. The report hasn't been written yet, but what I have done is taken a couple of screenshots there of some of the responses to the survey. I think the top one there, where the person has written, I think there are so many positive things about it.
We can't see the screenshot, or I can't.
Can't you? Can anybody? What can you see? What can you see at the moment?
Oh, I can see the peer-led research slide.
Oh, you can't see it on the other side. Can you see it?
Oh, sorry, I can now. That beneath. Sorry, yes, I can now. Sorry, that might be me. Apologies.
Thanks, Martin. Sorry. Yes, so there's a couple of screenshots there. I think there are so many positive things about enhanced harm reduction facilities. So really, really important point there. And what's really tragic about this is that the person who wrote this died the day after from an overdose. So the point made in the one underneath, please hurry up and do it, please. It's very, very important. Okay, I better speed up because I think I'm taking it too long. Okay, so in relation to peer-led research, the peers might be involved in guiding researchers as opposed to leading research and playing hugely insignificant roles in running the research. They might play a more guiding role, and in Wales we have something called the Lived Experience Expert Panel, the LEAP panel. So this is being set up as part of the Welsh Centre for Alcohol and Other Drugs that's led by Professor Wolf Livingston at Wrexham. So it's modelled on a research panel based in Sheffield that brings together peers who provide formal advice on research proposals and data collection tools. So it's still in its infancy, but it's been working well and providing invaluable advice to researchers at the start of their projects, in the middle and at the end. So researchers come to the panel and seek advice from people with lived experience on their proposed research. Peers might also be invited to sit on advisory groups, and we routinely do this now in all our research projects. And the peers provide hugely important guiding information on your data collection tools, your interpretation of your findings, and sharing the findings too, as well as collecting data. So we use them routinely in our minimum pricing for alcohol projects, our own evaluation of Buvidal that's been commissioned by Welsh Government, and also this example there from some research on substance use officers that's been introduced in Wales Probation Service. We invite peers to come and give guest lectures at our university for our undergraduates and postgraduates. Hugely important given that the students are likely to be the workforce of the future. And in addition to this informal, to all this formal work that goes on, there's also a lot of informal work. So I speak on the phone regularly, sometimes daily, to colleagues working in services, and they offer me support and I offer them support. So it's a reciprocal arrangement. Okay, the final thing I want to talk about, Martin asked me in particular if I would share a bit of information about some volunteering I did in Kaleidoscope in Gwent Drug and Alcohol Service a couple of years ago. So I thought it was really important that I get a better idea of how services work. As an academic, I'm much more removed. I drop into services occasionally and speak to people, conduct interviews, but I wanted to spend time in services to really get a better understanding of how they work. And so I managed to get a placement, and I spent a day a week for several months. And I spent time in methadone clinics chatting with patients, so I was lucky in many respects that I didn't have a specific role to do, so I was free to talk to patients. And I spent time going out with the assertive outreach team to see people who were in unstable housing, seeing how the services engaged with them and talked to them. And it was fascinating and eye-opening and so terribly sad at times as well. And those, some of the things that I witnessed will stay with me for a very long time. I witnessed all sorts of things, as you might imagine, going out with an assertive outreach team, but within the services and across all of that, I was so struck by the poor health condition of people with drug and alcohol problems, particularly those that living on the street. Huge health problems. They talked, when I spoke to them, they talked about difficulties in accessing healthcare, difficulties accessing GPs, the primary care, the real barriers to their accessing treatment. This was often because they couldn't get appointments, or because they feared the stigmatised views that are often presented to people with drug problems. And often this meant then they weren't getting the care for legitimate health problems, which was then getting worse and then requiring hospitalisation. But one really important thing that I wanted to flag up and finish on was the compassion that I observed from the staff working in services, who are genuinely caring, hunting for people living on the streets, checking on them, making sure that they're all okay, and trying to get them into services and get them the treatment that they really need. Okay, I know I've gone on and I'm sorry. I hope that that's been useful. Peers have a massive role to play in research, and the findings from that research can play such an important role in the development of future services that are fit for purpose and that meet the needs of patients, meet the needs of people with drug and alcohol problems. So thank you very much.
Thank you very much, Katie. For people, Katie will be coming back for questions. Can I also remind you that there is a chat, so that's quite useful. If you can see the chat function, pose any questions you want there, because that means that at the end of the session we can have those questions. Just a very brief on enhanced harm reduction. The issue of the enhanced harm reduction is basically providing a specialist service to those who are homeless, to offer them the opportunity to maybe take their drugs on facilities such as ours. But that would be, so it's basically building on what we have as a needle syringe exchange. And on the health issue, it is notable. For example, we have cancer charities, and they identify people with drugs and alcohol as the most vulnerable to drugs and to cancer. But when we ask them to bring their bus to go and test and talk to our clients, they will not come. So even though they're the most vulnerable, people will not actually work alongside people as the people we help. The second session is, which we'll be talking in more detail about how agencies are supporting vulnerable people, particularly people who are homeless, is from Chris, who is from Cranston. Kaleidoscope and Cranston actually grew up together, born in 1968 and 69, respectively. Cranston particularly have services in England and Northern Ireland, so you get a bit of a mix, and have a number of staff actually who are Scottish as well. So I think you will get a very good all-rounded UK perspective from Chris. So I look forward to hearing what Chris has to say, and I think it'll be very helpful to all of us. Thank you, Chris.
Thank you, Martin, and thank you for sharing. I'm just going to try and share my screen. Firstly, thanks to ISSUP UK for the invitation today, and to Katie for a fascinating presentation. They're really interesting. Okay, so I just need to check that you can see my presentation.
We can see, Chris. It's all good.
Okay, grand. I just need to move things around my screen a little bit so I can see what you see. Bear with me. Okay, hi. So as Martin introduced me there, I'm Chris Rintoul, an Irishman with a French name, and I'm the head of harm reduction at Cranston. I've worked for Cranston for about nearly 3 years. Previously to that, I have worked mainly in Belfast in Northern Ireland, often with people who are homeless, and very often more so with drug and alcohol dependencies. So this presentation isn't possibly going to be a really logical kind of pattern, but I'm hoping to present some ideas and some experiences. So I'm going to introduce some of those things as I go. Something that's really been of interest to me, and when I first heard about it, I knew it explained so much of my experience in working as a social worker in Belfast. And it's the inverse care law, which has been around for, well, as long as the Misuse of Drugs Act, and I think it's probably more relevant than the Act. But what it tells us is that the people with most significant healthcare needs are the least likely to have them met. And in the context of drug treatment, this law explains why those with the most problematic relationships with drugs or alcohol are not in treatment. The other thing that if you apply it slightly differently in a context that wasn't perhaps intended, it also applies, in my experience anyway, to services designed to help people who are homeless or at risk of homelessness, i.e. those with the most severe needs, particularly emanating from difficulties with their mental health, a history of trauma, and compensating substance use as well. They are also the least likely to get the degree of support that they most need to find a way of stabilization, perhaps, or at least to delay or prevent deterioration. So my opinion, and I'm pretty clear about this now, having looked across the Irish Sea and seen what's happened, especially in England, in terms of drug treatment over the last 10 to 15 years, is that we just need to get back to doing what we used to do before we had a change to the recovery agenda, and also the funding for drug treatment services was slashed and prevented us being able to do anything but the bare basics. And when you can only do the bare basics, you tend to be only picking the low-hanging fruit. And that's the reason for that image on the right-hand side of the screen. It becomes much more difficult to do the intense type of work which is really necessary to reach those who are the most vulnerable and have the most, I guess, difficulties in living and in their lives. So where are these folks? If they're not in drug treatment services, they're somewhere. Often you'll find them in prisons. You'll find some or many within hostels or supported accommodation, is I think the more appropriate term for nowadays, or in houses of multiple occupation. And the other place you'll find this group are in the streets. Now, when we say streets, actually we mean they're hidden. They're not going to be visible on the streets, apart from perhaps whenever they're looking for money, they're tapping perhaps to get some funds up. But very often by streets, I mean in the bushes, you know, in areas and places where people don't go, quite simply because they're private and you can use there, and you may be able to exist there without being harassed by members of the public, or some would, you know, have experienced what they would describe as police harassment as well. So they're often very high users of emergency services as well, the likes of ambulances and emergency compartments, despite often having quite a reticence to medical treatment for reasons which are reasonably understandable given the previous experiences of those services, which often haven't been excellent. But the key point is, why do we not see them in treatment, apart from the fact that we changed a very good system in the UK, not perfect, but a very good harm reduction-led system in the UK in favour of the recovery agenda, and also that the money in the system was stripped out progressively. And most of it's because people don't want your poxy 50 milligrams of methadone. Now, you can say what you like about methadone and whatnot, but one of the things it clearly does, it's protective against overdose, but only whenever people are at a therapeutic level. And when people are at a sub-therapeutic level, it doesn't work, or it doesn't work as well. And time again, people will say, look, it's no good for me. You know, I can't sit around waiting on, you know, 30 or 40 milligrams for, you know, months on end, etc., and run around to this appointment, that appointment, and so on, before I see myself being very gradually kind of brought up the scale a little bit. So that phrase has stuck with me and has kind of made me think a lot about how we approach the delivery of treatment, especially for this group of people who are so excluded. So who are the common people and what are their common issues? I doubt, I mean, I'm certainly no academic and I would never claim to be, but I doubt it'll be a surprise to anybody that the key things that you see almost all of the time are people, when they come to drug treatment services, for those lucky enough to be able to come and to engage and remain within drug treatment services, you see that look of poverty about them. And you also see that look of trauma as well. And those are the most common things that seemed to me up and down the country, both in Belfast and in Sandwell and in other areas that I work within or support the services and the work there provide there, it's poverty and trauma all day long. And if we were able to solve those issues, which I know are huge issues, we would be doing everybody a great favour. We of course can't do that, or we can't do that easily, but they shouldn't be something that we don't attend to, we don't keep in mind, and we don't try to do what we can to alleviate those. So I want to just sort of start to touch on things around drug-related deaths and the aging cohort, as they're known. Well, if this theory around the aging cohort, i.e. those over 40 who seem to die young, and they do, why is it that that is happening so much more in the UK compared to other European countries with similar levels of drug use and some similar levels, obviously, of poverty and trauma, no doubt, as well? And perhaps what we should be thinking about is this actually inequality on stilts, which is the idea that you get to a certain level of inequality where your chances really drop off the edge of the cliff. It's not that you're sort of going down gradually, it's that you literally fall off the edge of the cliff, and all the support really to you is then failing. And it is significantly challenging to provide that support unless you do the things that I'm going to talk about a little bit later. The other thing to say is that chronological age, and I know this is not necessarily news to anybody here, but chronological age bears no resemblance to the age of the body. By the time somebody is 40, if they've had that experience of maybe multiple episodes or years of rough sleeping, use of drugs, primarily either smoking or injecting or both, and by the time that you reach 40, your body's age is around 80. So it's no surprise that you may die in your early 40s. But I don't want to over egg the aging cohort idea. I think there's something else that might be responsible for that. Another thing which is a bit odd is about within Northern Ireland, it's the 25 to 34-year-old age group that are dying, and they're known as the ceasefire babies. And we really don't know why. It's an anomaly. It doesn't seem to occur in other parts of the UK, Scotland, and Wales, but very certainly is happening in Northern Ireland. Okay, well, the blame game, I guess, because this group of people that we're thinking about are very easy to blame for their own demise or their own circumstances. You know, we might often think about them as people who fail to engage with services. You know? Well, is that the case, or is it that our services fail to be engaging or are unable to be engaging because of resources? And another thing around, if you can engage, do you benefit? Well, perhaps if you don't benefit, you know, you're at fault. Well, another way of looking at that is to say, is there a failure to provide beneficial options? And that goes back to my point around that phrase, epoxy 50 milligrams of methadone. If we can't provide therapeutic options to people that work for them in their individual circumstances, it's us that are failing, not the other way around. We also know that about 5 to 10% of people who do come to treatment services and manage to engage and remain engaged and stay and achieve some stability, 90 to 95% of those people gain from their experience. But there's a 5 to 10% cohort that nothing works for. No other form of buprenorphine and methadone don't work for either. And yet we know it's not a lack of evidence, it's a lack of will. The diamorphine prescribing, injectable diamorphine prescribing works very well. I'm very fortunate to work within an organisation that we can provide that in one particular area, and I've seen the benefits in some people's lives. In fact, I remember a gentleman who is on that form of treatment and used to help out with some training that we've delivered for staff in this kind of co-production way. I asked him if he could help provide some training. He said, look, I'd love to, but I've got an appointment with my dentist and I haven't seen a dentist in 30 years. And I thought, rock on, that's recovery. to pass up an opportunity to do something that he liked to do and to get a few quid for the benefit of his own health and well-being, self-esteem. That really, to me, is what recovery should mean and does mean. So what do we do? Well, we have to go into the void, and we have to go under the bridges, and we have to go into the derelict shrublands, and we have to go into the squats and the condemned buildings. We have to find the people. So in conjunction with a colleague of mine who is an advanced nurse practitioner and a prescriber, a non-medical prescriber, we designed a service called DEMO, Dynamic Evolving Model of Outreach, for Sandwell, which is an area of the West Midlands. And it was based on stuff that I had been involved with in Belfast, which itself had been based on something that had been set up in Copenhagen. It was very much about boots on the ground, get out there, map the area, go at different times of the day and week, find the people, and you will find them. In fact, I'm going to be doing something similar to that tomorrow in a part of London where we operate a service there. So that's at the very beginning stage, but the demo model that we have established in Sandwell definitely has advantages to the Belfast and Copenhagen models in that it's nurse-led and has some really excellent advantages such as same-day prescribing, and also can provide a range of assessment of a range of conditions. But what we find more than anything else is it's housing issues. It's people who are living on the streets, not really the streets, in the bushes. They can't get accommodation. The accommodation isn't there for them. And in fact, the unofficial rule seems to be, well, you're near Birmingham, so why don't you just go there? Opioid substitution treatment is a key issue if we want to try and protect people and help them to achieve any degree of stability or to prevent deterioration, then that needs to happen. But also, quite alarmingly, it's severe and sometimes life-threatening health problems such as sepsis. In fact, there was not just one person, but I'll use one as an example, one young woman who, had she not had assessment for sepsis and agreed to go immediately to the hospital with her nurse, she wouldn't have survived the night. So in that sense, that service, and just for that one person, has been entirely life-saving. And the other idea behind this is that we don't try to push people into treatment, because if they aren't in treatment, there'll be reasons for that. If they didn't come before, why would they come now? That's something that we need to work on in the longer term, but it's not something that we say, look, the carrot and stick is here, we'll engage you here in the streets, but then you have to come to us. It didn't work in the past, and it's not likely to work in the future. For me, however, the next level really is getting people out of the bushes, such as you see on the left-hand picture there, which is a real picture of a part of England last summer, and into a van. We've talked about enhanced harm reduction services. I'm what we would say, I'm a strong believer in the need for supervised consumption spaces, particularly now with the risk of nitazines, and particularly for this cohort who are so unwell and could at any time die from a whole range of different conditions. So we need to be able to do more than just give injecting equipment, give naloxone, give advice. We need to be able to take them places where they can inject safely and in a way which has got some sterility, or in a place that has some sterility and reduces much of the risk. Anybody who's worked within supported accommodation or services for homeless people will be aware of the concept of tolerated use. And I'll pay tribute to Kevin Fleming, actually, who's really championed that over the decades. And some of his work actually has been really helpful across the UK, including in Belfast. So how is that affected by certain laws and certain cases in law? When you have the Misuse of Drugs Act 1971, which Martin has already described for us, the only thing that within the Misuse of Drugs Act that service providers have to do is prevent the use of opium or cannabis. And that doesn't mean that they have to kick people out if they're found to be using opium or cannabis. It means they have to act to prevent a recurrence of that. So simply if somebody has a joint in their room, they have a staff to go and say, look, you're putting me at risk of, prosecution here as well as yourself, because it's obviously it's a controlled drug. Will you please go outside and finish that and do so before you come back in? You record that, and that's your action. That is a way to prevent recurrence of something which puts that staff member at legal risk. Obviously, supply is a different matter, and it's not something which can be tolerated in any facility, let alone a supported accommodation facility for vulnerable people. A lot of the concerns really come from something known as the Winter Comfort case, which is quite a lengthy story, really. But there were 2 day centre managers who were unfortunately imprisoned for a number of months, although their convictions were overturned upon appeal in 2001. And they were imprisoned because they failed to apply their own policies. Their policy said that they would ask people not to attend the service if they were known to be supplying drugs within it. And they did that to a number of individuals. And the stipulation was it was for at least 8 weeks, or I think it was 6 to 8 weeks, and then they could return. What got them in prison was the fact that they brought them back into the service in less than that period of time, in maybe 4 or 5 weeks rather than the 6 or 8 that were stipulated. That sent shockwaves across the UK, including obviously over to Belfast and Northern Ireland. We were looking at that time, well, not at that time, but around 2007 or 8, how could we provide accommodation services for injecting drug users in Belfast? And we had no options, nobody would take them. And when we started to look at how we might develop a service that could do that, we were in fact presented with an issue coming from not the Misuse of Drugs Act, not from anything Winter Comfort related, but from the Criminal Law Act in 1967. Excuse me. And that section 5, which says that if you as an individual know, member of public, it's not, whether you work for a service or not, if you as an individual know of something that is being done by another person, which is an arrestable offence, which is drug use and lots of other things, I suppose, as well, then you must report that to a police officer within a reasonable period of time. And there was the potential for that to be used perversely. That was actually brought in the back of a border campaign of the IRA way back in the 50s and early 60s to prevent people withholding information on what was seen as terrorism. It was never assumed that it would ever apply within drug treatment or also within supported accommodation, but the theory was that it could have affected it and actually prevented it. I'm very glad to say that the police service in Northern Ireland worked with us and found a way past that particular part of the Criminal Law Act and could provide good quality accommodation. And what did we find as soon as that happened? Because the deaths were occurring in the Belfast hostels, and it was deaths that were occurring because of the secretiveness, because nobody was going to disclose use because you were going to get kicked out. So staff became the cops, and people who lived in the services became the robbers. So it was a game of cat and mouse, really, better description, I guess. But as soon as that was introduced, this new model, what we call DASP, actually, deaths in the Belfast hostel plummeted to absolutely nil, and successful overdoses were, overdoses were successfully reversed, many times over. And that was in the context of at one time there being an 18+ months waiting list for OST. So you weren't getting, thinking about 18 months in the day of a life of somebody who's homeless, injecting heroin user, you may as well talk about 3,000 millennia ahead. It's impossible to perceive. So they had no perception of ever getting the treatment. Sorry.
Just 2 more minutes because we just have a few more questions.
Okay, grand, thank you. So in the context of this absence of treatment, certainly at that period of time, deaths plummeted and successful reversals of overdoses jumped. And really it came down to one thing: being able to walk into the hostel and say to the staff, look, I'm heading upstairs here, I'm going to get myself sorted out, come up and have a look at me in 5 to 10 minutes time. Nod and a wink, all done. And perfectly legal to do so, but it took a shift in thinking for people to get there. But it worked when we did it. Okay, I'm not going to get through this. Apologies, I maybe spent too long on some of the other points, but what I want to do is talk about a couple of thoughts that I think are exceptionally important for this group of people, and this is around, in particular, the threat of the medicines. So I think that, I'm speaking on behalf of, I guess, treatment services and for every worker and manager within them, I think we're not taking the threat of the medicines carefully enough or seriously enough until treatment service workers keep and hold two thoughts in mind absolutely every time they see people. And the first one is, how can I be sure this person will come back to see me? What am I doing with this person today that is likely to maximize the chance that they'll come back and see me, or that I might go and see them at an agreed date? And the second thought is, how can I ensure that they remain alive in order for them to be able to come back to see me? And it's the coalescence of those two thoughts, which are front and center of minds, which I think will be the best thing that we can do to prevent loss of life through avoidable overdose. And this is my final slide, so I'll just say that there's a campaign that some of the drug treatment services, the harm reduction leads from various ones, came together and we discussed things that we thought what might help. And this was in the midst of kind of the summer crisis, especially around Birmingham, where people were dying in great numbers. And we felt that we have to get people engaged in what we call staying alive plans. There's no point us talking about overdose risk in abstract. We have to get people involved in that plan themselves. Like, they're the only person that's going to know when and where it's likely to happen, who might notice it, who could do something about it, how to get access to that person, and all these other methods that could be useful to prevent loss of life. So I think once those two thoughts that I mentioned in the previous slides there are in place, that naturally gravitates people to a staying alive plan. Thank you.
Thank you, Chris.
Thank you.
If you're happy to stay on the line, and Katie, if you're happy to join us, that'd be good. Very happy to see any questions from the panel. As I said, please feel free to use the chat line. I know we haven't got a lot of time, but I suppose one of the questions I'll say to bring you back in, Katie, is there's a lot of cynicism about, does research actually make any difference at all? Do governments or do agencies listen to research? What's your answer to that? I think you gave some hints in your presentation on that.
Yeah, I think they do. Well, certainly Welsh Government have listened to a lot of the research that we've done and the recommendations that we've made. So linking in with what Chris said there about the Staying Alive programme, we did some research a few years ago on overdoses. And one of the findings that we reported was that people were using alone, but they were thinking they were using with other people, but those people were in other rooms in the house. So whilst they were not using alone, they were using out of sight of other people. And Welsh Government Public Health Wales took on board that finding and then started to produce harm reduction advice that encouraged people to don't use out of sight. So it kind of shifted that original harm reduction message from don't use alone to don't use out of sight. So I think that, yeah, Welsh Government do often take on board the recommendations from research, and I think the peer-led the lessons from COVID and the Boothdown evaluation, I think Welsh Government have been very supportive and yeah, taking on board the results.
No, that's good. And Chris, in a way, a similar question. I mean, some of the good work that's been pioneered, do you feel that the UK government are taking some of those lessons on, or do you feel there's a bit of a vacuum there?
Well, I guess my response to that is probably pretty predictable. I think there are a number of fronts and a number of things that should be shifted quickly. I mean, Misuse of Drugs Act is itself a problem, but particular aspects are also in difficulty because, you know, we give out nitazene and xylazine test strips. We talk to people about sending stuff to Wales to Wemnos, which is a fantastic service, and we're in deep gratitude to them for it. But I want to do testing upstream. I want to do it before people are using it. I want to use the new technology which is available. But we need support from the Home Office to allow us to do that in ways that don't put our staff at risk of prosecution. That would be a very simple thing to be able to achieve. I've seen great progress made through the loop, and some early examples of that starting to come, but I think it needs to be quicker. It needs to be deep down and dirty. It needs to be, you know, handheld devices, used mobile, you know, when you're out doing your outreach in your van or in your car, etc. That's how far upstream we need to go. We need to go there before people use, not, you know, a week afterwards or, you know, maybe hours afterwards.
And I think when we're looking at the homeless population, I quite liked the idea that we go and seek people out. I mean, certainly we're trying to enclose it, but I still think we're primarily centre-based. Do either of you feel that there is beginning, or do you feel the shift has happened in terms of actually making sure services are there and going to the people who are furthest away from accessing treatment?
I'll maybe come in on that then. I think being able to do that has to be both in the imagination and in the minds of the services that are there to serve a particular area, but they also have to be resourced appropriately to be able to do that. I'm not being at all critical of services that just don't have the capacity to do it because the money isn't there. We need better support. I mean, the Dame Carol Black money in reports has been useful, but it's really just a start, you know, and I think that needs to continue. And also, I think it's kind of perverse as well. The more you expect people to engage in treatment or say, we're going to do this so long as you come along and see us on a weekly, monthly basis, whatever it is, you know, the less likely it is for that to happen. We must bring treatment to the people that are most affected by substance use problems, and they're the ones that are hidden in the bushes. They're sometimes no matter than a few hundred meters away from your service, you know, the building that you operate your service or services from, but they're entirely unknown to the staff that work within them. That can't be right. You know, those people are only spitting distance away, but none of them are known to the service.
And from your experience, Katie, I mean, with the peer work, were you picking up people who weren't in services, or was it all people who were in services when you were doing that work?
Engaging in the research, yeah, no, I think it was people who were outside of services as well. But what I was going to say in relation to your question, just before that, the lessons learned from COVID project really highlighted what was possible during lockdown, that services went out and provided support to people in community. And I think that then led to some new initiatives like the Spike on a Bike in parts of Wales, you know, taking needles and equipment out into the community. Peer-to-peer naloxone schemes, I think, probably were born partly during the lockdown period. But I'm not sure what that noise is.
No, I'm not sure.
But yeah, I think there are some really good examples of outreach where outreach work is you know, working very well. And yeah, but it's forever a challenge, isn't it? Like Chris said about bringing people into services who are not come into services for a very good reason.
Yeah, I think that is a big factor in terms of sometimes we're not offering the services that people want. So, you know, for example, methadone, I think you highlighted the issue of methadone. For many people, it's saved thousands of people's lives, but for other people, they feel that it's just a substitution which is more addictive than the drug they had. If that's right or wrong is another matter, but I do sometimes worry that we're quite limited in the UK of the treatment options. I mean, certainly Buvidal, which is a long-active replacement, is helpful, but there's very few examples, which used to be quite common in the UK, for example, of diamorphine or heroin prescribing, isn't there? Which, in a way, is what some of the people that we work with are effectively asking for.
Yeah, I'll tell you something. Some people refer to methadone and who are prescribed it in fairly negative terms. And yes, there is some, in my view, some validity to the idea that it's more difficult to stop using it than it is heroin itself. But you got to remember, it can be titrated, whereas heroin can't. You know? But we don't have the range of options that people want. And when people have been through, you know, formulations of buprenorphine and also methadone, and they're not benefiting, that's on us, I think, to find things that might benefit them better. And it's good to see that there's a new player in there, you know, in the country in the terms, that's Buvidal. Although it needs to be used carefully and not in the way it was in Belfast during lockdown, because there's a direct link between it being the new drug, the new wonder drug, and an HIV outbreak. It's too long to go into here, but it was most certainly a consequence of inappropriate use of Buvidal.
Yeah, and I think that's the thing. We've got to give people choices and options, but certainly with Buvidal at the moment, we've got more people wanting to use it as a substitute than we can afford at the moment, and there is this issue of affordability, unfortunately. Now, I'm not quite sure. Our time is gone. I think it's 3:05. I don't know, Kirsty, if we're allowed to carry on or what the. We will carry on.
Yeah, if you want to answer some more questions, you can carry on for a few more minutes.
Oh, that's fine. Sorry, Kirsty. Just checking that. Again, if anyone has got questions in the panel, I'm hogging it somewhat in terms of the questions that I'm asking. I suppose if there was one thing you feel that agencies should do in terms of supporting the homeless, what homeless population in the wider sense? So, you know, people who don't have a home, so that includes people in hostels as well as sleeping rough. What would you say we should be providing? I'll come to you first, Chris, because you're more on the ground, and then Katie can be thinking of the theoretical models she's picked up.
If you work in substance use treatment services, don't dump and run once you get somebody into a hostel. It's not good. It doesn't work, and it's not right. You know, the degree of skill and stress that there is for workers working within supported accommodation and services is almost unique. It's really, you know, amazing when you get good workers, but we can't afford to kind of just, they're in accommodation now, that's grand. You know, you need to work with those services. Equally, those providing supported accommodation or housing outreach type services, they need to see themselves as not, well, that's the drugs team. They do all that, you know, we're not paid or funded to do that. In reality, you know, Jimmy, you know, is probably seeing 4 or 5 different workers if he's lucky, right? If he's fortunate enough to do that, right? All of those 4 or 5 different workers are from different agencies, have different functions and roles, right? But they can't divorce all the other needs or things that are going on with Jimmy's life and that he needs some support with, and by saying, no, that's not our job, you know. And so all agencies need to be able to say, look, it's holistic here. We may be funded for one particular thing, but we have to work across the boundaries and support one another in terms of the services that are provided.
That's good. Katie, have you got any words of wisdom?
Well, not really. Just expanding a bit on what Chris said. Yeah, so I think it's that holistic approach, isn't it? And providing support to individuals across all of their issues and problems. Co-locating services or representatives of a whole range of services within one space would be great. So people don't have to travel around to lots of different organisations, tell their story over and over again, and relive the traumas every time they do that. So I think, yeah, that treating the person as a whole person and dealing with all of their problems together would be the dream.
And I do think you're right about particularly co-location of health services. I sort of feel that our service users have high risk of cancers, and by the substances they take, particularly alcohol, for example. They have high risk of dentistry. We know that a lot of people who take drugs have a very sweet tooth, for example, but also they're not getting basic remedial care in the first place. And eyesight, all those health issues that they're effectively being denied need to be looked at. And I think the other cohort of people that I was shocked in Wales, going to a centre where people have just been released from prison. And a lot of them, there are no places for them to go to, so they're literally now just going back on the street. And the facility that I saw was so shocking. I mean, I asked my workers who are running the service, they're working with some of the services, did they prefer the new residents there coming out of prison being in prison or in the residential facility? And it was 50-50. I mean, how can it be if we're moving people from prison to the community and provide a facility that is no better than the prison they've come from? So I do think on those things, if we want to bring rehabilitation and change, we must do that. So any last comments you want to make? We've got about a minute. I'll go to Katie first.
Nothing in particular. Thank you for inviting me and for giving me the opportunity to talk about peer-led research. It's so valuable, and I think it benefits so many people, everybody involved in the research process, and giving the peers a voice is so important, and it can help shape services.
And Katie, if people on this call are from more, I mean, anyone can, but more academic, would you'd be happy to be contacted in terms of giving some advice if people wanted to go and do peer research? I'm assuming we can put that in the
yes, I'd be very happy to.
And Chris, you've got the final word. I'm not even going to take the final word. Well, I might do.
Thank you, Martin. Yeah, I want to imagine myself as an old man in 20 years' time, right? And thinking back, going, on earth did we not allow overdose prevention facilities long before we ever did?
Yeah. I mean, I am an old man, and it still hasn't happened. But hopefully, when I'm an even older old man, then yes, we might have real change. And I think the main thing for me, the take home, is that what we're learning as services, I hope, in the UK, and I think through research, is that we have to co-design services. We can't. I think the traditional model is we have a service we want to offer people, and we have a vision of how we want to provide that service. But sometimes we haven't actually asked the end user about what is it the services they want. And I think if we're going to move forward, particularly with more vulnerable communities who are feeling disenfranchised, we've got to get them to be active participants in the way that we provide services to them and for them. Okay, well, thank you so much for helping me on this difficult and tricky subject, Katie and Chris. It's been a pleasure working with you, and thank you everyone who has been listening to the conversation that we've had today and the presentations. Thank you very much, and hopefully we will see you in some form in the future. Thank you all very much.
Thanks, Martin. Thanks, everyone.
Thanks, Martin.